So here we go. All right. So welcome to another CarePatrol education series on the topic of the difference between assisted living and skilled nursing. And before we dive into this topic, let's meet some of the CarePatrol team that's on the call today. But first, I think for those that aren't familiar with what CarePatrol does and how they help families and providers, Cindy, I think you were going to give us an explanation of what CarePatrol is all about.
Yes, thanks, Steve. I'm Cindy Yar Evans of CarePatrol, the Baltimore-Annapolis corridor, and we cover part of Baltimore County and Anne Arundel County. But overall, CarePatrol helps seniors and their families find safe senior living options. Our service is free. We typically help them find assisted and memory care, but some independent living as well. We're all local and hands-on, and our process is to learn about the seniors' clinical needs, what their financial capabilities are, and where they'd like to live. And then we sort of act like a real estate agent and show them and tour with them options that meet all of their needs. Because beforehand, we've gone to all of these communities to check out their clinical capabilities, staffing ratios, and amenities and other things about them. Their deficiency surveys are important as well. We're able to assist the seniors through the whole entire process and hopefully make that a lot easier for them. We are we have 7 franchises across the Maryland, DC, and parts of Virginia and Delaware. And we're all very lucky to be able to advocate for our seniors and their families.
Great. Okay, well, this is one of my favorite parts of these discussions is we get to go around the Brady Bunch graphic here and get to meet the rest of the CarePatrol team members and learn where they're from. And I'm going to start with Charles there on my left. Charles.
Good afternoon, everybody. Welcome to the latest CarePatrol educational presentation. My name is Charles Picard. I am the CarePatrol representative in Prince George's County. I also work in Charles County, and I share the District of Columbia with Bonnie Danker and Robin Edwards. And to add to what Cindy said, I was thinking the other night, and among all of us who are CarePatrol franchisees in this area, we have well over 60 years of combined experience in helping seniors in the community. So we are really out there and serving seniors in every community where we are. We're very local. So welcome and thank you all.
I love it. And Charles, at Bonnie Danker, that's a great segue for Bonnie Danker, who's below you on my screen.
Good afternoon. Charles, thanks for that introduction. I just went over that 60 mark. Welcome. We're really glad you're here with us today. We think this topic today is one that we have found that families are really struggling with. And so we're really excited to have such a wonderful group of professionals to assist us in bringing this to you. I own the franchise area for Howard and Montgomery County of Maryland. And as Charles said, share the district. We're very fortunate to have many colleagues throughout the United States, as well as our Baltimore, Washington area. So we're here to help support families in this navigation of care and housing.
Great. And then under there on the bottom, but definitely not on the bottom, it's Robin Edwards.
Glad I'm not on the bottom. I'm Robin Edwards. I'm with CarePatrol of Northern Virginia, and I serve Fairfax, Arlington, parts of Prince William County, and a little part of Loudoun County. Welcome, everyone.
And then up on top there, although now I've just completely, forgive me, everything is my fault. Okay, we got Paula Sotier.
Welcome, everyone. I'm Paula Sotier, and I'm the owner of Baltimore, most of Baltimore County, Baltimore City, and Harford County. Welcome. Look forward to speaking to you.
And in our center square right now, we've got 2 of our panel members for our discussion. So I'm going to hold off and let them introduce each other here in a moment. but I want to do a couple of other little housekeeping things. Whoops. First, I cut and pasted everybody's contact information into chat so that you can reach out. And I think there might be one or two CarePatrol team members that are missing. But before we dive into the discussion, I want to make sure to spotlight Seabury at Springvale Terrace, which is this month's sponsor. And I believe we've got Kathy on the discussion. Kathy, did you want to jump on the screen and tell us a little bit about Seabury at Springvale Terrace? Let me see if I can unmute Kathy. All right. So Kathy, if you can unmute yourself. If not, we can do this at the end when we do what everybody looks forward to, is spinning the wheel of names. So oh, there you are, Kathy.
I'm actually Gina. Kathy has been in another event, so she hasn't been able to come on, but I'll be representing, I believe, Seabury at Springvale Terrace to talk about assisted living.
Okay, great.
Oh,
Yeah, just tell us a
like
little
that?
bit about Seabury at Springvale Terrace.
okay. So we're both independent and assisted living community. We take residents or 62 and older. We have a good structure in between the independent and assisted living. It's called the enhanced personal care. That's a level in between where resident or family member needs to have medication management, supervision while bathing, with the meals and the housekeeping and laundry. That program comes in between. But our assisted living can go up to level 3, which is just one step lower than nursing home.
Great. All right. And Jessica, if you want to drop your contact information into chat, that would be unbelievable. And with that, I think for the CarePatrol team, I don't think I missed any pre-event housekeeping. I think we're ready to kick your panel discussion off. So I've got a PowerPoint here. Share my screen, and then I'll let you guys, I'm going to drop my camera off the screen and I will let you all kick things off.
Great, thanks, Steve. So many of our families come to us and they say the feeling that they have is overwhelmed and that they're searching for assisted living, nursing home, memory care, Alzheimer's, and they're not really sure what they're searching for, but they know what they don't know, and that is that they don't really understand what is the difference between long-term care and assisted living. And so that's the purpose of bringing you this discussion today. Today, we're going to talk about a number of different objectives. We're going to start off talking about the definition of assisted living, nursing home, and long-term care. We'll review the different types of assisted living because there are many different types of assisted living throughout the community areas that we're talking about, the tri-state areas. We'll also dig a little deeper into financial resources for assisted living. Our colleagues, Rochelle Clark and Akila, are here with us from the village of Rockville, which is a rehab and a nursing center, and they have tremendous amount of years of experience. I don't know if we're going to hit them with the 60 plus, but that might be aging them a little bit higher than they are. But they're going to be with us as well to really speak to those areas of long-term care. We're going to look at long-term care approval. How do you get approved for long-term care? What does that process look like? How do you pay for long-term care? Again, very important area of concern. And then we'll talk about the types of patients in both, or residents as they're referred to, in both long-term care and assisted living. We'll wrap it up with services offered long-term care and kind of do a comparison between the long-term care and assisted living. And then You can put your questions up in the chat or the questions and answer as we go throughout our discussion today, because we want this to be as interactive as possible. But if we're not able to address a question within the context of our conversation, then we have left time at the end to address those questions. So from here, I'm going to kick it off to our next slide, which is really looking at nursing homes versus assisted living. And Akila and Rochelle, can you take it from here?
Good afternoon, everyone. My name is Rochelle Clark. I'm the admissions manager here at the Village of Rockville.
And I'm Akila Lane. I'm a social worker here at the Villages of Rockville.
So at our community, just as an overview, we not only provide rehab as a short-term basis and long-term care, but we are a continuing care retirement community, also offering independent living as well as assisted living and memory support. So today, our goal is to discuss the definition of a nursing home.
So for a short-term rehab stay, you're in an inpatient facility and it's offering skilled nursing, physical therapy, occupational therapy, and speech services. Long-term care offers all of those services as well, but the billing is different.
So long-term, and we'll expand upon that in a further slide, it can be paid either private pay with VA benefits or with long-term care insurance.
Thank you. And then on the assisted living side, you'll have myself, Bonnie, Paula, and Robin, who will be speaking today to the assisted living and how that works. Assisted living is defined as housing for elderly or disabled individuals, and that provides 24/7 care and supervision. Also in assisted living, we'll touch upon this a little further, but there's also support with what are called activities of daily living. We hear a lot of different terminology kind of tossed about in the care industry, and activities of daily living are an important part of the care that's provided in both assisted living and nursing home environments. Assisted livings are governed by the COMAR regulations throughout Maryland. And just to give you an idea of how extensive assisted living is, there are over 1,449 different assisted livings in the state of Maryland. Pretty astronomical when you think about it. How does a family navigate that and figure out what's the best options for them? And that's where we come in. Then in Northern Virginia, my colleague Robin Edwards is with us today, and she covers that area. And there are over 126 assisted livings in just that area of Northern Virginia. From here, we're going to move to the next slide, and we're going to be talking a little bit more, digging down a little bit deeper into how the framework of cost is associated. And Rochelle and Akila, I'm going to turn it back over to you again.
Okay, so for a nursing home for short stay rehab, those are typically covered by Medicare or private insurance, or even private pay, depending on if you're here for respite. Whereas long-term care is mostly private or Medicaid or long-term care insurances.
So Robin, I think you were going to cover this next slide.
Yes, for assisted living, as you can see, Washington, DC is very expensive. The cost that was estimated was $72,000 a year. I'd say now it's considerably higher. And likewise in Maryland, it's $60,000, a little bit less. The percentages you see on the side there reflect the increase in price from the previous year. From there, we'll go to the next slide.
No, go one back, Steve. She's going to finish up in Virginia.
Okay.
Okay, got it.
Okay, so yeah, likewise, I didn't see that one. So likewise, here in Virginia, the cost for nursing home care, as you can see, listed at 91,980. And that's in 2019. And for a private room, it's considerably higher, 105,000, over 105,000. In assisted living, again, you can see that the cost here on average for the state is about $58,200 a year. And with that, we can go to the next slide.
Thank you, Robin. Hi, this is Paula. So I just thought I would take a few moments to talk about the kinds of assisted living and then how do you pay for it. The first type of assisted living is called It's called Continuous Care Retirement Community. And this is a community that has really all sites of service. So they have independent assisted living, many have memory care, and they also have a long-term care nursing home, and some have actually rehab there. This community has an initial investment, and the initial investment can be anywhere from about 200,000 all the way up to over $1 million. They also have a monthly fee, and that can change on the type of model you have, but suffice to say that this doesn't usually happen. You don't usually go to a CCRC out of a hospital rehab. I've been in the business 8 years and never once discharged someone right into a CCRC. The best part about a CCRC is the benevolent fund. So for those people who are worried they're going to outlive their money, they can still stay at the CCRC with this fund that will help them. I did place a nurse that worked her whole life, and she was really worried about that. And we found a very good a CCRC for her to live in, and she's very happy. Next slide. So the next kind is assisted living communities, or sometimes you hear them called rentals. They're larger communities. They can have independent assisted living and memory care, or some just have assisted living and memory care, and some just have memory care. So there can be all different kinds of these types of communities. Their monthly fee ranges from a little over $4,000 to $10,000. The interesting thing is it does matter. Bonnie talked about the activities of daily living. So the level of care can add to the monthly price. All of these communities in assisted living will have 24/7 nursing and take care of the client. The advantage or the difference of the assisted living communities is they tend to have apartments. They can be all different sizes, anywhere from studios up to 2 bedrooms. They tend to have more amenities. They can have transportation to doctors. They can have transportation to, lunch and dinners. And they have more activities throughout the day. So this can be, if someone is really social, this can be a great option. Next slide. The residential assisted livings, I think, are the ones that have the most questions. In Maryland, we have about 1,200 of them, if you can imagine. I call them a really good value. They are houses that are licensed with COMAR, just like the large community. Sometimes the staffing can be better because they tend to have between 3 and 12 residents. So if you have only 3 residents and you have 1 staff member, the ratio is 1 to 3. It is more home-like because it is a home. You can have private rooms, you can have semi-private rooms. Sometimes most of the time you're sharing a bathroom, but there are some where you can have your own bathroom. These they're all different kinds. Some can have stair lifts, some can have ramps, some can do more activities or less activities. So this is a really good option for some of our residents that may not have, $5,000 for assisted living. Next slide. So CarePatrol always gets a question, I'm sure almost on a daily basis, how do I pay for this? Well, really the bulk of the pay, 95% of all the clients we place, it's private pay. And private pay means their income that comes in every single month and some of the assets they have. So that's typically what pays for assisted living. There are 4 other ways to pay for assisted living. The first one is called the Medicaid waiver. I'm talking about the waiver that's in the community, not the waiver you can get once you go to long-term care. So in essence, you're at home. In Baltimore, I just want to give you some idea. There are 30,000 people on the list, and it's a 5-year wait list. So this is not a benefit that you're going to get when you need it when you leave a hospital. It takes time to do this. As of February 1st of this year, the income level in Maryland is you cannot make more than $1,482 per month. And that's the gross number. It's not the number that comes into the bank, right? So sometimes that confuses clients. You can only have assets of $25,000 or less. And the nice thing is that the state is trying to prioritize this a bit. When they look at the 30,000 on the list, they're trying to say which of these folks need assisted living the most. The next funding source is from the Board of Aging, and it's called the Subsidy. And you hear that there's the subsidy was $650. We're lucky in that many times it's up to $1,000 a month. They are only in residential assisted livings, and these residential assisted livings are approved by each county. So for instance, in Baltimore, there are 29 of them. Virginia offers an auxiliary grant. So they're a little different, but they still have some money for residents that need some help. The nice thing about this is the financial income level is higher. With the subsidy, it's $2,904 per month. And for a couple, it's $3,797 per month. You can have a little bit more assets, $11,000 for an individual and $14,000 for a couple. Here's the problem, and I get asked this all the time, and I know my colleagues do. They say, I have a resident that has $1,000. I know the subsidy is $1,000. So can you find me a subsidy residential assisted living to take this client? And I wish I could say yes. But the problem is, at least in Baltimore, and I know it's even higher in Anne Arundel and Montgomery and Howard counties, in Carroll County, I only have 2 out of the 29 that will take $1,800 as income and then add the $1,000. So I know this is complicated and hard, but that's one of the values we can bring. We know which one of these, can take someone at $1,800. The third kind is long-term care insurance. It's a great benefit. A lot of our seniors have paid into it over years. There is an exemption period, which it can be anywhere from 0 to 100 days, where they won't pay for the assisted living or memory care. So you have to have some funds to cover those 3 months. But then you get, your policy says you get so much per day. So it's really nice. It can, I've seen 3,000 all the way to 10,000 a month. So it's a really good insurance that some of our seniors have. The last one is VA aid and attendance. Steve, can you change? So this is probably the one we use the most, and is one I'm most excited about. If you're a veteran, you get up to $1,936 a month. If you're spouse of the veteran, you get $1,244. You do need the discharge papers, which is the DD-214. These are just some of the military dates that you have to be in. They're for the seniors. Obviously, there are more wars we've been in, unfortunately, but these are some of the dates. Steve, next slide. The nice thing is how you qualify. You have to have 1 day in active military service in wartime. You have to have been in the service 90 consecutive days. You have to have anything but a dishonorable discharge. So if you were discharged because of medical reasons, that's fine. You have to be married to the veteran at the time of death. So as good as this benefit is, the problem is it takes anywhere between 3 months to 9 months to get the money. It is paid retro. So if you apply at the beginning of December and it takes 3 months, you will finally get those 3 months paid back. So the challenge we have in placing someone is we need to be able to cover the gap time, right? That's what I call it. A lot of times they have some assets that will do it. Sometimes the family will help. And if those two things are not available, there is sometimes the availability where some of the residential assisted livings will sign what's called a promissory note. And that means between the family and the community, they say, we promise you that when we get paid, that payment, the retro payment will go back to the community, and then the payment going forward will go to the community. Next slide. Okay, I'm turning it over. Akila and Rochelle?
Yes.
Okay, sorry.
So the next question is, who do I contact to admit into a rehabilitation or a long-term care? In most cases, depending on the size of the long-term care facility or skilled nursing facility, your contact would be an admissions coordinator, an admissions manager, or someone who's called a liaison. That person can be a clinical personnel, such as a nurse, or more of a business professional. So the first step in seeking placement is by contacting the admissions office to find out if they have a bed available. So you want to make sure that they have a place for your loved one, whether it's in a private room or a semi-private room. For those that may need special accommodations, you may ask for accommodations such as if they need a bariatric bed, which is a larger bed for someone who may be larger, needing larger equipment. And part of that process into being accepted is both a clinical review as well as a financial review. For the clinical review, most often a hospital representative, a social worker, or a case manager would fax a referral to that accepting facility. That accepting facility representative would review to make sure that that individual's needs can be met through the capacity that that facility has to offer. So we want to make sure that if that individual needs a trach or they need some type of complex care, that the facility nurse and staff are able to manage their care. Part of that process is really important, is making sure that the patient's insurance is in network with the accepting facility. So that representative at the facility may be an admissions coordinator or a manager. They're reviewing and checking the insurance benefits to make sure that that person has days remaining under Medicare if they're going in as a short-term rehab guest. And if they have a long-term care placement need, they're reviewing their finances to make sure that they meet the criteria for that facility and or making sure that they have the long-term care Medicaid approval. Next slide.
So for short-term care, like rehab, there's usually a qualifying 3 midnight stay at a hospital, but due to COVID, that's typically been waived, and that's currently still being waived at this moment. But for short-term rehab, the goal is short-term. It's to return your loved one back to a prior level of functioning to where they're able to complete their ADLs, which is their ability to walk or brush their teeth and regain their prior level of abilities and carry out the activities of daily living. This type of help is managed in changing the conditions. The goal is to return to the prior level. And it's typically paid by Medicare, Medicaid, or private insurance.
Subacute care also includes a nursing care component as well. When it comes to inpatient therapy, that's also offered, but the nursing care component is key. For inpatient therapy, subacute rehabs also offer physical and occupational as well as speech therapies. The nursing care component can vary based on the facility's capabilities. So in general, you may have a facility that can provide antibiotic therapy, medication management, medication administration, wound care, hemodialysis, peritoneal dialysis, catheter care, pain management, and respiratory needs. For more specific information on the capabilities of an individual skilled nursing facility, I suggest that you do reach out to the respective admissions office for the facility that you're seeking placement.
And for long-term care, the services are similar to short-term care, what's being offered. It's the payment, the financial criteria that is typically different. Because for long-term care, there is like you do have to qualify medically as the services for individuals. The individuals are typically like 65 and older and either have an intellectual disability or physical disability. And they're both typically eligible for Medicaid and Medicare. Long-term care services can be paid by Medicaid, long-term care Medicaid, and long-term care insurance and private pay through your own personal funds. The daily rate will vary from facility to facility. For example, here at the Villages of Rockville, our daily rate here as of 2021 is $436 a day. The long-term care services and supports are provided in home and community-based settings, as well as in other institutions. But for the purposes of this webinar, we'll typically just be discussing here at a skilled nursing facility. Next slide.
So Medicare pays days 1 to 20 at 100%. Day 21 to 100 is, there is a Medicare copayment for this year of 2021. The copayment is $185.50 per day. So depending on the supplemental insurance, if your patient or client has a second insurance, that supplemental insurance, depending on the insurance, may pick up a portion of that $185.50 per day. Some insurances may pick up 100%, 80%, 0%, it just depends. So the responsibility of that admissions representative at the facility that you're seeking for short-term rehabilitation, they should be checking the insurance for your loved one or client and communicating what that patient responsibility is to you. For long-term care payment and coverage, that can be covered, as Akila mentioned, under long-term care, Medicaid, private funds, or through long-term care insurance. At our community, for example, our residents, once approved, do have to pay the bill upfront in advance and then the claim with their long-term care insurance provider. So some examples of long-term care insurances are Genworth Financial, John Hancock, and Transamerican, but there's so many out there. Next slide.
So for medical services for the patients here at a short-term care rehab, it can typically vary. It can be like they're typically medically complex. And by that, I mean, if they require a 2-person transfer or a Hoyer lift, they require a ventilator or they have a trach. They need IV therapy for antibiotics. They have a PEG tube for feeding due to just like speech issues, swallow issues, wounds, stages 3, 4, at different levels. There's also dementia care as well with uncontrolled behaviors, and some that may require a locked unit. We also offer physical therapy, occupational therapy, and speech, both at short-term and long-term. Long-term, there's more restrictions of when these services can be offered. And hospice services is offered for long-term care, but we don't offer the hospice service. We have a hospice agency come in and we will provide the housing and the nursing care while they're here and receiving hospice services. But it's not a service typically offered in a nursing home.
Do we want to go back to that previous slide and we can touch upon the other piece of it, which is really the assisted living. So with assisted living, the medical services, you have assisted livings that can provide a high level of care in a supported setting. For medical issues, there are some assisted livings that are able to support somebody who needs a two-person lift, as they refer to it. There's also some assisted livings that are able to support people on a Hoyer lift, meaning a special piece of equipment that assists the caregiver in transitioning that individual. Also, assisted livings, a select group of them can provide insulin for those individuals who are what they call sliding scale, which means that it's changing throughout their day. Some assisted livings in general are not as communities that are able to provide tube feedings, but there are a select number of assisted livings with that enhanced level of care, meaning they have caregivers that have additional licensing and experience who can provide tube feeding, but that would be more of a case-by-case look. There are a number of assisted livings that really specialize in care for individuals with dementia. Many individuals in assisted living have dementia at some level. However, there are also some communities that are just dementia specific and really work with individuals who need that higher level of supported care and maybe more of a higher level staffing because of their needs for supervision and reminders. Assisted living is also able to provide PT and OT and speech therapies, what they call more on an outpatient basis, which would be covered under your Medicare Part B of your insurance. And assisted livings also allow hospice to come in, and hospice does not replace the care at the assisted living. That is usually provided by their caregivers and their medical technicians. But hospice would be an overlay of care, overlaying and supporting the care given by the staff at the assisted living, or in the other case at the nursing home. And that would come in through a different agency. And again, many times your hospice benefit would be covered under your Medicare insurance. Thank you, Steve. Next slide. Back to Rochelle and Akila.
Great. So just one thing to note, I know this next slide addresses the services for short-term rehab and long-term care. For short-term rehabilitation, when we talk about Medicare as the payer, it is a bundle reimbursement for all the services you see. Some communities, that may vary where the patient has to pay for services for a phone or maybe cable, but I just want to state that our community, it is all inclusive. There's no extra fee when you're covered under Medicare outside of your co-payment. So it's very similar when you're in short-term rehab and long-term care as far as the services. It's 24/7 caregivers that are provided, licensed professionals. So you'll typically find a licensed practical nurse or registered nurse that's there 24/7, along with what's called a geriatric nursing assistant. So that's a caregiver who's met hours to be able to assist an older adult with all of their activities of daily living. Inclusive of those services are also 3 meals per day, snacks, laundry, housekeeping, as well as supplies related to the care of that patient. When we talk about medications, when you're covered under Medicare, again, it's reimbursed under one daily reimbursement from Medicare. So that is no additional cost. But for long-term care patients, they may have a co-payment depending on who's paying for the care. If they're private pay, they will have to pay a co-pay on their medications. But for those that are Medicaid, we cannot balance bill them, so that would be included. So I just wanted to make that distinction there when it comes to medications. Personal care is included, as well as physician services. For instance, at the Village of Rockville, we have an attending physician, a medical director, and other specialty doctors that operate out of our clinic. And so all of those services are on site. and are most of the time billed to Medicare Part B. Incontinence care and supplies are also included as part of the service, as well as any access to a registered dietitian and licensed social workers are also available.
And then in comparison to assisted living also would have 24/7 caregivers, and assisted livings are under the direction of a delegating nurse. So that nurse's license is over the assisted living, a little different from nursing homes where they're under the direction of a medical director. Many assisted livings also have awake caregivers. They have to under COMAR regs if they have dementia clients who would be up at night and have a risk of needing support. Assisted livings also do provide care with the activities of daily living, which are defined as bathing, dressing, transferring, toileting, and medication administration. So they're licensed through level 1 through 3, providing that level of supportive personal care. Many assisted livings at this time also do have physician services, a primary type physician group that comes in. They're also bringing in mobile X-ray, mobile lab, and many times they would help coordinate that care under that primary care physician practice that calls on their residents. They also do bring in many times podiatry, and some even now have mobile dentist and ophthalmology, which is pretty incredible, being able to turnkey. Assisted livings many times are, as part of their care plan for their resident, are going to be administering their medications. If someone passes a test and is able to administer their own under their delegating nurse, then they can administer, but I'd say it's probably less than 5% of the time a resident's going to self-administer. They would also manage ordering those medications and pulling them through a pharmacy. So there's a lot of supported services that the assisted living can provide. And many times I think that's an anomaly for many families that we work with, in understanding that they've really come a long way in being able to provide more care and support than just assistance with independence. Next slide. And here we are to the question and answer. As a panel, I have my colleague Paula Sotier, myself, Bonnie Danker, Robin Edwards, and we are all senior care advisors with CarePatrol. And we have our other colleagues as well in the audience who are here to answer any questions or concerns that you might have regarding assisted living. And then you see Rochelle Clark and Akila at the top, and they are here to answer any concerns or questions regarding long-term care, rehab, how do you get in, how does it work, all the different things that they touched upon today. And so we welcome your questions, and we open it up to the audience for their questions at this time.
Great, and I'm glad you went over the panel there, Bonnie, because that was the first question, is to reintroduce the panel. But let's see, Sonia has some questions here, and the first says, what responsibilities do assisted living facilities have to their residents who become COVID positive with no symptoms to manage, especially if your mom or pop, are there any mom or pop communities, are there any resources for that type of situation? Yeah, COVID has definitely added a unique layer to families' concerns.
Well, let me start, Bonnie and Robin, and then you can add to this. So residential assisted livings do very similar things that the larger communities do. First of all, they have been very good about getting their seniors vaccinated. All right, they have, done everything they can. They've gotten, whether it be CVS or whatever, to come to their community. As I'm out and about, I would say the majority vaccinated. It's not 100%. Then the next question is what happens with the staff? And I think can be all over the board. I know I'm on a mission to be talking to owners of smaller communities to please get their staff and themselves vaccinated. I've had one owner that wasn't, and unfortunately she brought COVID into the community, which was very sad. Like good news, nothing happened to any of them, which was great. As for if someone gets COVID, the idea is that you have to isolate them. Sometimes that's difficult in these smaller communities, right? Because they're in a semi-private room. So I did have one smaller community have a private room that they left aside in case that happens so that they could isolate the client. They have very similar rules about wearing masks and 6 feet apart and washing your hands and taking your temperature when you come in. So many of my residential assisted livings have what I call COVID stations. I don't know a better word to say, but you walk in and you sign in, get your temperature. They ask all the questions and you go in. During the height of it, just like all the large communities, there was a lot of visitation outside. If they had an area, some of them made areas. I mean, they were very creative. So that's would you add anything to that?
I think that
Alright.
covers it unless the person sending in the question has anything that we didn't touch upon. Make sure that we're on point with their question.
Great. Okay. Yeah, Sonia, feel free to add to that, but great explanation. And Sonia has another question. What happens if a patient comes in skilled, and the family can no longer care for them? And let's see, what happens if the patient comes in skilled and the family can no longer care for them and wants the family member to become long-term care? Oh, maybe what happens if the patient comes in assisted and then needs to transition to skilled, but the facility doesn't have any long-term care beds? So I guess this would relate to a continuing care community.
Steve, Akila can answer that question from a social work perspective.
Great.
And that does happen where the plan might initially, the family will have them come in as they're going to return home and maybe have services at home, but realize that the care isn't going to get any, like they're not going to actually be able to return back to their home or back to their community where their prior living was. So that the plan may transition to either an assisted living or long-term care. And as a social worker, when they come in, we would discuss that with the family, with the interdisciplinary team, and kind of come up with a plan of, okay, well, if they're not able to go home, giving the family the options of assisted living and making referrals to different agencies, like different assisted livings, or connecting them with organizations like CarePatrol to help the families find assisted livings that can meet the patient's needs, or even internally, like having them transition to assisted living here if that's in their benefit, or even long-term care. But that's also part of the discharge process of when a patient comes in, we do that assessment and connect them with admissions as well as the business office to determine, like, is long-term care an option? Is it an option here? Do we have a bed available? If not, then we also coordinate with other nursing homes as well to transition a patient from ours maybe to another facility for long-term care.
Okay, great. And then Allison asks, is there a different staff to patient ratio in assisted living compared to nursing homes? Oh, unmute. Yeah, Rochelle and Akila, I think you need to unmute if.
Okay, I didn't know if you were addressing us. I apologize. So it's going to vary based on the number of beds and just the capacity of that facility. So for instance, in our assisted living, we have 50 apartments and we staff based on, the needs of our residents. And so it's typically a 1:8 or 1:10 ratio in assisted living. And in rehab, depending on the census, which can fluctuate every day, which is the total number of residents that we have daily. So as you can imagine, because we admit post-acute hospital stay and folks are going home, which Akila is doing the discharge for, we have admissions and discharges every day. So that staffing ratio can fluctuate, but typically to meet the needs of our residents, to be able to respond to their needs in a timely manner, we try to keep our ratio about 1 to 8 as far as our census. So that's 1 licensed registered nurse to 8 other residents. And again, that can change based on the shift or the day, depending on what's going on day to day.
Great. Let's see, Sonia, who asked about the COVID, had a little follow-up to that question, and she says that there have been lots of patients brought to hospitals COVID positive because they cannot isolate the patient. And then Allison wanted to know, does anybody have any details on the ratio in assisted living of staff to residents?
I can speak a little bit to that. It varies. At a lot of the larger communities, it's roughly about 1 to 8, 1 to 7, but it depends on the care level of the residents at any given time. Sometimes they will increase the staffing if there's a need for it. But yes, it depends on the acuity levels of the folks that are there at any given time. At the small care homes, you know, as Paula mentioned before, it's going to be a smaller ratio with typically 1 to 3 to 8 residents, or 2 to 3 to 8 residents.
Okay. And
I think one thing that's helpful for many families is there's a document called the Uniform Disclosure Statement. And it is a document that is a uniform document throughout the state of Maryland. And as part of that document, it goes through the different services and amenities at a community. And it also has the information on the staffing ratios at different times of day and the license level. So that's a helpful comparison tool, I think, to use when comparing and contrasting assisted livings, nursing homes, and residential assisted livings. It's also an important tool because if you have a long-term care policy, many long-term care policies have stipulations as to how many hours a week there's a registered nurse, a licensed practical, or other professionals in a community in order to meet the criteria of that policy. So just as a rule of thumb, that can be a really helpful tool to ask about or to get a copy of.
Let's see, Christine asks, how would you advise a PT who has long-term care Medicaid to look for a bed, a patient? Okay, how would we advise a patient who has long-term care Medicaid to look for a bed? So if somebody qualifies for Medicaid right now, any words of wisdom to seeking a bed? I know sometimes that can be challenging.
So community Medicaid and long-term care Medicaid are completely separate. So even though you qualify for community Medicaid, it doesn't automatically transition to long-term care if you're planning to stay. You still have to apply for the long-term care Medicaid through your admissions office and still like completing the paperwork because it is 2 separate services.
Right, but Rochelle, this is Paula. Would it be, it's a bit easier if you already have community Medicaid? Is that a true statement?
Yes, that's what I'm told by my business office
Yeah.
professionals who are Medicaid specialists. Yes.
Yeah. So one question from one of my colleagues that's here in my office is, how do you recommend if we've got clients that are in assisted livings and need long-term care, how do they do it? Like, how do they get into long-term care if they really need it?
The first step is applying, inquiring about bed availability. Most of the times you might find the facility has a bit of a wait. So making sure that you get on that wait list by completing an application, and they will reach out to you once they have a bed available. As far as eligibility, there's information you can reach out to either the facility's Medicaid specialist or to maybe someone that's advising you from a financial aspect, an attorney, to find out the information regarding eligibility for Medicaid. So yeah, that's the first step.
So to get a level, we've got clients all the time that ask me that. Who do I get, or how do I help them get a level?
So if they're coming from, typically a level is usually done at the hospital.
I know.
So by the social worker or the case manager at the hospital, and they'll go through Telegen. And that's where where Medicaid essentially assesses the patient's medical complexity needs that will require a 24/7 skilled nursing care that has to care like a trach, wound care, peg tube, physical disabilities, like restorative care to do the physical therapy and occupational therapy and speech services to see if they will qualify for, depending on the medical complexity.
So can you get a nurse, like a, I don't know, care manager to get a level? Are there nurses out there that can do that for us?
Outside the hospital, I'm
Yeah.
not completely sure. I would think that you would be able to through Intelligent, but I'm pretty sure it still has to go through the county. You still have to it'll probably be a different situation than just buying through the county long-term care Medicaid instead of it technically being a level of care.
Okay.
Because because for levels of care, it's typically going from a higher level to a lower level.
All right. Okay. So let's see. Can one have Medicare and community Medicaid? Do you know the income cutoff for Medicaid per month? Yeah, once the door opens on Medicare and Medicaid, it always changes the dynamic of the conversation, doesn't it?
So the answer is you can have, it's called Medi, right? You can have both. The income level of Medicaid doesn't change if you have Medicare.
Okay. And then Lisa Morris has a comment. She says a physician can fill out the paperwork for a level of care.
Ah, that's good. Thank you.
All right. And then let's see, we got a few other questions here. Oh, this is a good one. I don't know if anybody can answer it, but it says, what are the chances of most of us needing long-term care? Anybody have those stats?
Oh,
So
God.
I do. Genworth did a study and part of the findings was that every day until 2030, 10,000 baby boomers will turn 65 and 70% of them will require long-term care in their lifetime. So,
There you go.
Wow, Robin, I'm really impressed.
That is awesome. That
Yeah,
is a good number.
Let's see. And then oh wow, it's almost 2:00, but let me I got one more here. How many days does Medicare pay 100% in a skilled nursing facility? Did I stump the panel on that one?
No,
What was the question?
It's how many days does Medicare pay 100% in a skilled nursing facility? So I'm discharged from the hospital, I'm in a nursing home, and they've told me that Medicare is going to pay. How many days would it pay for?
So Medicare typically pays days 1 to 20 at 100%, and starting on day 21 for this year, the co-payment is $185.50 per day. Part of the verification process when coming into a skilled nursing facility, the admissions office is asking that patient and verifying if they've used days previous within the last 60 days. So they have to have a 60-day break from skilled nursing to hospitalization in order to have 100 days and reset. So they have 100 days in the benefit. If they admit to a facility and haven't been anywhere else in the last 60 days, and they have the first 20 days covered at 100%. And depending on what the secondary insurance is, the supplemental, that insurance will pick up a portion of the $185.50 per day, starting on day 21.
Okay, great. Wow, another great discussion, y'all. And again, thanks to the audience for asking some really good questions here as well. Any closing thoughts? Any additional items that you want to share? Okay. Well, I once again want to thank the Care Patrol team for inviting me to moderate. Thank Springville Terrace for sponsoring this month. Thank all the panel members, Rochelle and Akela, for joining the Care Patrol team to help navigate these options. And I've recorded today's discussion, so I will get the link out, and we will see everybody next month for.
Wait, the wheel.
Oh, the wheel. You can't forget the wheel. Geez. Okay. All right. So let's see. All right. I wonder, do we still have Jessica on board from Springville Terrace?
Gina.
Yeah, it's Gina.
Oh, Gina, sorry. So Gina, I'm going to spin this wheel on your behalf because I believe that's part of your sponsorship, is providing a prize or a gift card. So here we go. Let me share my screen. And we are spinning the wheel here to see who's going to win. And it's
Ooh,
Jordan Ward.
all right, way to go.
So we will make sure to get Jordan Ward an email and get that prize out.
Yeah.
Okay. So Care Patrol, if I covered everything that needs to be covered?
I think you did a
Thank
great
you.
job.
Thank you.
Great.
And
Oh,
this month
Jordan
of
Ward is in
Thanksgiving-
the audience. Hey, this is always great. Congrats, Jordan. So, okay. Well, we'll see everybody in December, and thanks again.
thank you.
Take care. Bye.